Ladies and gentlemen, good afternoon and welcome to today's webinar with Professor Veller. We're delighted to have you for today's event and we look forward to engaging with you on this very pertinent topic that has gripped the world in a way that many, if not most of us, have never witnessed in our lifetimes. COVID-19 is a topic that has dominated all news and media platforms for most of 2020. And with that has come countless questions born from fear, worry, anxiety, or just simply wanting to plan around it or either learn how to live with it for the foreseeable future. Today, Professor Veller will give us some insights into various aspects of COVID-19 by answering questions that some of you have sent through to us, and we'd like to thank you for those, as well as questions that you're welcome to post throughout the session. We invite you to use the question and answer section at the bottom of your screen for any questions that you would like to have answered, as well as use the chat function for any comments or remarks that you would like to share. Like I said, Professor Veller is looking forward to engaging with you today. And so it is an honor for me to introduce to you Professor Martin Veller. Professor Veller is the Dean of the Faculty of Health Sciences at Wits University and a professor in the university's Department of Surgery. He's an expert in vascular surgery with extensive academic, research, and teaching experience with no less than 7 books, 18 letters, comments, editorial comments, and book reviews, as well as 116 invited lectures, to mention a few of his accomplishments. Professor Veller serves on the board of directors of the Wits Donald Gordon Medical Center and the Wits Health Consortium. He has trained at the Wits University and at St. Mary's Hospital at London's Imperial College. Ladies and gentlemen, please welcome Professor Veller, Martin Veller. Over to you, Professor.
Good afternoon, and thank you very much, Heather, for that introduction. It's an absolute pleasure to have this opportunity to chat to some of our alumni. One could hardly imagine that we would be doing it in this rather extraordinary manner using a webinar. In comparison, normally I would have been sitting here, well, certainly not sitting at home in my own study, but certainly would be in a lecture hall wearing a suit and tie, and here yet in neckties sitting in my study. As indicated, these are remarkable times, and we had the opportunity of reflecting on this during a meeting of the executive in the faculty this morning, when we were reviewing the outcomes of a strategic meeting that we held on the 2nd and 3rd of March of this year. At that time, while we obviously were aware of what was happening in mostly in China and the countries in that region, the only thing that we were interested in was making sure that there was hand sanitizer in the faculty. And we had little idea that what would happen in the next 5 months would really overtake us. Interestingly, on the 3rd of March of this year, there were only 90,000 cases of the coronavirus, or known cases of people who had been infected by the coronavirus at the time. And yet today, we are in the world have more than 23 million cases and are adding on a daily basis somewhere in the region of 250,000 new patients who have been known to have been infected. This pattern of having about 250,000 additional cases per day has been around with us for at least the last month. I'll remind you that the first case that was found, or what was recognized in South Africa, was the man who'd returned from a holiday in Italy, and that was on the 5th of March. And today we are again at more than 600,000 cases. So clearly the very short interval, and Heather pointed that out earlier, has really been remarkable in what it has managed to do to the world and to us and to South African society. This point I need to just be upfront and just pause for a second and to warn you that while the title of this talk is that I'm going to be able to answer all your questions, as a surgeon, I'm not an expert, but I have obviously, for good reason, had to become a keen observer But most importantly is that I have been in the position to interact with a remarkable faculty, and also within the university, with amazing people in our setting. And in many ways, it is always the pride that one feels as being a member of this university is what the impact that this university makes, even in very difficult times, as this is these are causing us. So I'd like to take this opportunity to do, in the next few minutes, basically three things. Firstly, just to reflect on some of the responses that have come out of WITS and particularly the people in WITS. Then very quickly talk to our response in the faculty to the issues related to the ongoing training of healthcare professionals in this unusual period of time. And then finally, very quickly make some personal observations about the effect of this pandemic on South Africa. And then we'll obviously open it up to questions, then to see how we go forward. As mentioned, the faculty is a remarkable faculty, and again, with a little bit of bragging, currently the faculty in the Times Higher Education ranking of universities across the world ranks the faculty 77th in the world for clinical and preclinical disciplines, which is clearly remarkable if one thinks about the fact that there are somewhere in the region of 25,000 faculties across the world. And what is again been evident, as I've already indicated, is how people within the faculty have been so important in managing aspects of this pandemic within the country and within our region. Examples of this are lot, but I'm just going to very quickly pick a few. The first is that the leadership of the National Institutes of Communicable Diseases is based within, or academics are academics who are based within our faculty. And they certainly were central to the preparations and the preparedness that this country was in prior to the first number of these cases coming in. And I must say that, again, while there have been many areas that have been possibly problematic within the management of the epidemic in this country, it would have been substantially worse if there hadn't been this amazing leadership amongst people such as Lynn Morris and Cheryl Cohen. The other is that undoubtedly a number of the research institutes in the faculty are amongst the world leaders in the implementation of broad public health interventions in the management of viral diseases. And that we clearly got out of the invidious situation that we are in this country, where we do have probably the largest concentration of people living with HIV and AIDS. And many of these institutes have had a remarkable impact in the management of that pandemic, and continues still to do so today. And it was very easy for many of these institutes to harness their expertise as the new pandemic of the coronavirus arrived, and to use their skills in terms of trying to firstly find new ways of managing the virus, but also to look at some of the other public health interventions. Probably the best known of the trials that was developed, or at least not developed, but was implemented in this country, is the World Health Organization Solidarity trial that looks at a variety of antiviral drugs, as well as in the initial phases was going to look at hydroxychloroquine and interferon beta-1 alpha in the treatment of severe cases of the coronavirus infection. The third area that one wants to highlight is that we're also very fortunate that we have one of the leading vaccinology institutes in our faculty. As many of you know, been much in the media around some of the trials led by Professor Shirbir Mahdi, who I'm proud to say will be taking over my position as Dean in the beginning of 2021. And they've been involved in two major trials. One has already gone a long way. That is the vaccine that was developed within the Jenner Institute at Oxford University, which is an adenovirus vector user, or an RNA gene that is carried by an adenovirus. And the more recently introduced Novavax vaccine trial, which is a protein-based vaccine. Now, the importance of these trials being conducted, obviously, in South Africa is enormous, not only because of our varied population and by the fact that, in fact, we are able to, for instance, test these vaccines in HIV-positive populations, but also because it is important for the African continent to be involved so that we hopefully in time will also have access to these vaccines. And as I'm sure we'll discuss, is probably the one thing that we really need to hope will become a successful component, because treatment using other means is unlikely to achieve the same level of long-term immunity that is required to ensure that this novel coronavirus eventually will become one of the nuisance viruses in our normal milieu. In the clinical setting, we also have had enormous impact with many of our clinicians being central to not only the management of patients with the coronavirus infections and many of the very severely sick, but also because many of them are in leadership positions and have been able to develop the protocols and the management guidelines that are required in order to effectively take on a new disease of this nature. Members in our clinical team have also been involved in developing a number of the coronavirus hospitals. An example is the Nasrec site, where our Department of Family Medicine was significantly involved. And then just outside of the faculty, a number of other also remarkable interactions and impacts. In the Faculty of Science, Bruce Malada and his team, in conjunction with the Itemba Labs and Data Convergence, have developed not only a very accurate modeling program that has been, in fact, remarkably accurate, certainly in the early phases of this disease. I think that they didn't quite see the extent of the community-based evolving of this disease, but certainly in the early phases, they were able to bring the country onto a reasonable level. And I think that they probably missed the first significant peak probably by as little as 30 days. The other is that their tracker, and I can only commend it to you, is one of the best forms of keeping or being informed about what is going on in this country and getting information that is helpful to understand what's going on. And then in the Faculty of Engineering and the Built Environment, they were very early in developing some very novel and cheap means of developing personal protective equipment, and have been doing a lot of work in helping our workforce stay safe in these difficult times. And finally, then, I think it is important to also mention the very significant number of student volunteers that came out of our faculty and other parts of the university, who, when called upon relatively early in the pandemic, came forward in large numbers. Well over 600 of our students volunteered at that time to largely get involved in some of the task shifting that was required to be able to put qualified healthcare workers into the primary treatment environment. But also many of them have been involved at the coalface, often taking on some of the less dangerous tasks. But I think that we need to recognize that this has been one of those remarkable components about what happens when there is a call for help, and how many people in this country come forward to be part of the effort that eventually gets rid of this scourge. Turning to what happened within the teaching environment, the faculty had its first contact with a student who was infected by coronavirus on the 17th of March. We became aware of it on the 19th of March. This is one of our clinical students, or in the early phases of their clinical training, and clearly caused a significant amount of consternation. Clearly, we had by then already looked at very carefully a lot of the protocols that were being discussed across the world. But having now reached the point where we were, in fact, had probably the first student in certainly our university, and it sounds like also within the country in this environment, and that was a clinical student, put us under a little bit of pressure. We were in a position very rapidly to take these students out of the clinical setting, and did so well before there was any risk of any spread amongst the student body. We isolated at least we self-quarantined the people who had been in contact with that student, and we then looked at how to manage the way forward when other events started to overtake us. And that's the weekend that we then started very seriously having a number of additional potential contacts across both the faculty and the university. And the university then on the Monday after the on the 24th of March, we then made the decision to go into early recess. That early recess was also to make sure that we were able to clear our residences, so that we at that time were concerned that that would become a place in which significant contact occurred, and that if we did have any of our students in the residences becoming infected, that would become a hotspot. So we, at that stage, started clearing the campus and the residences. Many of you will have come across the very interesting legal challenge that BITS was faced with, where two of our senior students challenged the university in wanting them to stay within the residences because they felt that that was a safer place to be, and that they didn't think it was appropriate for them to travel back home. As you all know, the university was supported in its decision by the judge, and we then were eventually in a position where we sent everybody home. And as you all know, the lockdown was announced on the evening of the 23rd of March and was then implemented at midnight on the 26th of March, which forced us then very quickly as a university to think about how we were going to go forward with this. At this stage, it was evident that this virus is going to be around with us for a long period of time. At that time, we were fairly clear in our minds that we would not be able to bring students back for the remainder of the first semester of this year, and therefore started quite seriously looking at managing our teaching and training responsibilities using online means, which meant that we had to bring in or develop systems that allowed our students to access that, which meant that we, for instance, had to procure a very large number of laptops for our students who didn't have laptops. We had to ensure that they had appropriate access to data. And what I must say is that in these incredibly difficult times, certainly within my faculty and with my view also right across the university, we've been able to really create a circumstance where the evidence that's in front of us is that we have lost very little other than the circumstances that can only be managed in true contact environments, so laboratories, field trips, and in the clinical setting. Because of the importance of bringing on or ensuring that our health professionals would be able to go into, who are in their final year, were able to go into their professions at the end of the year, we fought very hard to bring our clinical training students back onto the platform quite early on. We were able to do that just as the country came down from level 5 lockdown into level 4. And certainly our final year students were already then back, and we were able to bring back our other clinical training students very soon thereafter. And for that reason, it is currently our view that we are going to be able to graduate and, where required, progress students into the next year of study by the end of the year in that setting. That has also been after some significant engagements with both the Department of Health and thereafter with the Department of Higher Education, also been possible across the country. But it did take quite a lot of persuasion as we were considered at that time to be doing something that is quite dangerous. And there were massive concerns that we were doing this at a time at the cost of student security and safety, and had to manage that obviously very carefully. Let's then very rapidly turn to a few observations about what is happening in the country. And again, I'm sure that most of you are well aware of what is going on, but just a few things that I think are pointing to a slightly different picture to what we were, or what is directly reported by the numbers. As indicated earlier on, we went into just over 600,000 cases in this country a few days ago, and with 13,000 deaths, the first time into the 13,000s overnight. But what is it really? And I think that the 12,000 deaths, if we compare that against what one sees across the world, that's a case fatality rate of about 2%, a little bit more than 2%. And across the world, there's a view that that is low. But if we look at other data, it is very likely that the South African case fatality rate is probably closer to 5%. So if we look at the information that we get from the Medical Research Council Burden of Disease Research Unit, they reported that the excess number of deaths in comparison to what they would have expected to occur since the beginning of May is that there are roughly 36,000 more deaths in the country than they would have expected. This is 36,000 deaths in people over the age of 1 and who have died from natural causes. So the question really is why is there this discrepancy? And I think that it's fairly clear that the number of people who are dying in identified environments or being identified to have died from COVID-related complications is being underreported. I am fairly sure that the 36,000 is not all, that all those 36,000 people only died from COVID-related complications. It's very likely that there may well have been other socioeconomic issues that have been brought on by the pandemic. But it's certainly fairly clear from that information that the mortality is closer to the 5% than the slightly higher than 2% than is commonly reported from the official statistics in this country. What is interesting is that as many of you I'm sure are aware, is that the rate of infections are reducing as well. In the latter part of July, we had roughly between 13 and 15,000 new cases reported on a daily basis, and we are now well down into the 2,000 to 3,000 rate. And what is also interesting is that the new mortality rates are also decreasing quite dramatically. So it's quite clear that something is happening in this population that is resulting in these reducing rates of infection. Incidentally, the reproductive rate, the R0 rate, currently is considered to be somewhere in the region of 1.1, and clearly we would like to see it below 1 in order for us to get some degree of control, but clearly that control is going to be temporary, because everybody obviously does expect over a period of time another resurgence of this infection. So the question then really is why are we in this setting? And I think that there's a lot of evidence, although it's not as yet all that clear, that there have been many more infections in this country than we have recognized. And just a few observations in this line. So Shabir Mahdi informs me that in the early phases of their recruiting into the Oxford vaccine trial, when they were screening individuals, 1 in 4 individuals at the time were testing positive on PCR. The number when they were started the trial in their Hillbrow site had gone up to 1 in 3. That the infections that many people have asymptomatic infections, I think, is now well known. And it's very likely that that's the reason that we haven't been able to pick up as many infections as probably there are in the population. We obviously also have had some significant problems in terms of testing in our country. And it's quite clear that if one looks at the distribution of the illness or of the virus across the country in areas where there are going to be a high number of people being tested, then the number of infections is substantially higher than if compared to places where fewer people are being tested. Just to give you an idea of that, currently roughly 4% of our students in our faculty who are back on the platform have tested positive, compared to a positive rate of infection in the Johannesburg population that is hovering around somewhere around the 2%. So, and why would we have a higher rate is purely because we have got a higher degree of suspicion and are going to be testing those people well before other circumstances. Another statistic in that line is that 1 in 8 individuals who works within one of the private hospitals where there's an active testing program have tested positive for this virus, which clearly means that they are, and these people are not the people who necessarily are in patient contact. And while that hospital does treat patients with coronavirus complications, it's often the people who have not been in contact with patients that have become infected. So what is the reason then, or what are the likely or the possible reasons that we are currently in a situation where the infection rates are dropping? And we need to think about that in the observation that there is no evidence that any of the public health interventions that have been around in the last few weeks have been any different to those when we were in the very early rapid phases of rapid rise. Therefore, it really has to be something innate and immunological, in my opinion. And it clearly is speculation, but it is fairly clear that it is probable that we have somewhere between a 15 and 20% rate of infection in the population, and that's enough to, at this stage, start slowing down the infection. As I pointed out, this is pure speculation. We don't have evidence around it. Certainly where we have seen serological information in other parts of the world, it's often been found that there are anything between 5 and 10 times as many people who have antibodies compared to the known number that have been infected. And that is information that comes from the San Francisco area. It's information that's now available out of New York, in Geneva, and in fact in Kerala in India as well. So clearly, there is immunity in the population, and it's very likely that that has had an effect. The virologists also tell me that there's likely to be some degree of cross-immunity, particularly in children, with other coronaviruses, and this may be the reason that certainly young individuals, particularly in densely populated environments in this country, have also had a lower rate of infections. Finally, just a very quick thought about the effects of this pandemic on the economy in this country. And there's no doubt that it has had a massive impact, and where we stand at the moment, and certainly a number of us started writing about this already as early as April, when it became apparent that the hard lockdown was probably costing the country in the region of $1 billion to 2 billion rand a day, that one needed to think about managing the lockdown so that it didn't shut down the economy, but that one needed to also bring in social or at least societal measures that would manage the reduction in terms of the infection rate. And I think that the fact that many of these interventions that we talked about at that stage have become the norm is something that I think we can really start thinking has taken us to this position where we are today, where we're in a position where the economy is slowly reopening. We clearly are still in a phase where the infection rates are dropping. Clearly, in time, there is a risk that our infection rates are going to go up again, and what we're going to need to do is to go into episodes, as has been reported today in the news, that advice has been given from the World Health Organization advises that we need to be looking at particularly the mortality rates and using those to move the country into less severe restrictions when the mortality rates are going down, and then more stringent levels of restriction in terms of movement as the infection rates and the mortality rates are going up. I think that this is a great opportunity to start taking some of the questions. I see that there are quite a few already on the question and answer environment, and I'll pick a few of those up. I'm going to try and to pick those up as I see them on the question and answer environment. But also would appreciate if the organizers of the event also would help if there are some specific questions. So I see here's the question about the mortality rates in the MRC disease burden study, and there's no question that there is some underreporting that is apparent to us. What those numbers are always going to be, and I'm sure that you've also seen some of the controversy about what the actual baseline is and what those numbers are, is there. What it doesn't, however, surprise me that we are currently at around that number of somewhere in the region of 30,000 excess deaths. Just to give you a little, and to make this more realistic in terms of what that number actually means. The influenza pandemic that affected Italy in 2015, 2016 was reported to have an excess mortality of somewhere in the region of 27,000 deaths. Now, Italy and South Africa's population numbers are very similar. I think Italy is just over 60 million, and we're just under 60 million. If you think about that in terms of influenza being, essentially is normally reported to have about a 0.1% mortality rate. That kind of 27,000, or the 30,000 acceptably in a relatively short period of time kind of fits into the clinical observation, where this is obviously a virus that has got greater level of mortality in that grouping, but is still not totally out of the ballpark. The issue obviously is how long this will go, and if we have the general observation is that this virus will be around for a long period of time, and it'll be important for us to find some ways of intervening, and clearly that's only going to happen once we get a vaccine. Estimations around vaccines have been all over the show, as many of you will have read. Over 260 vaccine candidates, around 30 already in study. But what we've been told, even if we have a very rapid outcome in terms of, for instance, the Oxford vaccine, that it'll please take us, it'll take us at least another 6 to 8 months before those vaccines are going to be widely available. So this is going to be a longer environment than we expected. I'm going to try and just so I'm just looking at this discussion around this, the question asked about student volunteers. Absolutely, we are going to recognize the student volunteers. I think that it's the question of how one does that. I mean, volunteerism in some way does mean that people give of themselves, but certainly the important aspect is that they should be recognized. The one thing that we've tried very hard is that they're not in any way being disadvantaged in their studies, and currently we make sure that their volunteering is done in extra time and not in a circumstance where they are going to be disadvantaged from a time perspective. I see this response regarding the pursuit of those involved in corruption. That's been an absolutely disappointing component. I must say that certainly many of the observations that have been made that the corruption, particularly around PPE, is tantamount to attempted murder, is something that I have a lot of empathy for. I think that we're going to obviously have to manage that quite carefully, largely because I think, again, we must not overreact to circumstances that are not always fully clear to us. But the one thing that we do need to do is that we have to develop a concept of social solidarity in the fight against a pandemic of this kind of nature. And without social solidarity, we clearly are in a circumstance where we will only make the whole situation worse. We did have a few questions that were posed prior to the event, and I just wanted to raise a few of those just because they are, I think, quite important in terms of trying to understand some of the dilemmas that we face. So one of the areas that has become really quite controversial is the accuracy of the PCR test. As you know, the PCR tests for the viral RNA, and generally the PCR test from a technology perspective is quite an accurate test. But what is very clear is that there are a significant number of false negative tests. In other words, when people have got the virus, but it's not picked up on the PCR. The so-called the false negative rate is currently considered to be somewhere in the region of about 15%, so 1 in 6. And the primary reason for it is probably from a clinical perspective. So firstly, the timing of the test, and it is well known, or at least recognized, that today that the test is most likely to be positive between 4 and 6 days after the infection. And that, often the testing is done too early. Certainly when we are concerned about somebody having had a contact, we will generally only test after 4 days and generally at about 5 days. The other area that's very clear is that there are significant sampling errors. It's a test that is not that straightforward to do. There's a lot of argument now whether one can do it from buccal saliva as opposed to nasal saliva. Having undergone the test now, the sampling on a number of occasions, it is not the most comfortable thing to do, but there seems to still be some evidence that the nasal swab is more accurate. The importance about the false negative rates is that a positive test therefore should hold much more weight than a negative test. And I think it's also one of the issues that we have had in terms of having to understand why there are so many unrecognized cases also in our environment. There has been a question in the question and answer about, are there more rapid and more accurate tests? I'm not aware of any. I mean, I think everybody has seen the controversy about the various tests for antibodies. And the question has always been is whether these antibody tests are not just accurate, but also reliable in terms of what they're doing. And I'm certainly not an expert in this field, but I am concerned that there are people who are starting to talk about rapid antibody tests in the diagnosis, and that certainly, in my understanding of this condition, has no place. The issue in terms of immunity is another one, and there's a lot of talk, firstly, about the rapid decline in the immunoglobulins, in other words, the antibodies after an infection, and the question of whether, and this is true for both those people who've been infected by the virus as well as with those who've developed their antibodies as a result of a vaccine. The question is that then going to give us a long-lasting immunity? And the answer quite clearly is nobody knows. There's a hope that the cellular component of immunity, in other words, that related to the T lymphocytes, is going to be longer lasting than the humoral immunity. But there really is still not much evidence around that. And certainly there are case reports of reinfections, but observing what we've just said about the PCRs, whether those people are directly infected, are carrying virus or are infected, is always going to be an area of some concern. The other aspect in terms of immunity is this issue in terms of cross immunity. While there is not much work around it, it certainly is quite clear that when people do get infected with a class of viruses, that there generally is some degree of cross immunity, and there is clear evidence that in the normal run-of-the-mill seasonal coronavirus infections, that there is a degree of cross immunity. This serological test for antibodies were approved by SAPRA. I just understood that that it was removed again because of some inconsistencies that they came up. I haven't had a long chat to the people related to this whole situation, but it does talk to the broader concern about some of these serological tests and what they would be able to do in terms of the diagnostic. Certainly in the longer term, the serological tests are going to be important for us to understand what has happened in a community, but we're still a long way from having information related to that in South Africa. There's a question about in the UK, non-COVID disease healthcare has really suffered due to the measures taken by the NHS England. And yes, there is a similar picture in South Africa. We certainly have already seen in at least 3 areas a significant change. So one is the immunization rates in many of the communities in the country has gone down. Shabir Mahdi talks about the reduction in terms of the number of children that have been appropriately immunized. And as you know, he is an expert in that field and really some concern. And certainly a lot of what has been done around those immunologic, that vaccination programs has been quite substantial. There also has been some evidence that the non-communicable disease complication rates have increased in recent times, and that there are more and more people being seen with complications of diabetes, hypertension, and heart disease. And unlike what we've obviously seen in terms of the trauma mortalities, which are clearly down. And then the final evidence that's in front of us, it's been reported to me that suddenly we've seen a significant rise in the number of in number of children presenting for oncology treatment at 1 or 2 of the hospitals, which appears to indicate that for reasons that are not clear, that children had been withheld from these treatments for a period of time. Question about any possible explanations available for the apparent low death rate in this country. As I indicated, I think that the death rate in this country is higher than is reported in direct consequence to COVID. We obviously have about 3 times as many, we have 3 times as many deaths as being reported ascribable to COVID. If one discounts a significant component of those for other reasons, non-COVID related, at least non-direct COVID related, then the mortality rate is very likely in this country still to be at about 5% of known cases. Where if we then take the circumstance that there's anything up to 10 times as many unrecognized cases, then the mortality rate is obviously going to be somewhere in the region of about 0.5%, which is what it looks like from a clinical perspective. As I indicated early on, the mortality rate associated with influenza is considered to be about 0.1%. And if we eventually come to a point where the population-based mortality rate is somewhere in the region of 0.4 to 0.5%, that kind of fits into the clinical picture that is being seen in this country at the moment. But we will only have that information when we really are a long way out. And certainly then the question arises, why would we be lower in terms of our mortality rates in comparison to, for instance, Italy, the UK, and Spain? And that may well just be an age issue. The median age of people in this country is about 27.5 years. The median age in the UK is 40 years, and the median age in Italy is about 47 years. Another clue in that is that if we look at the excess deaths in this country, and look at the age group, a third of the excess deaths in this country occur in people under the age of 60. 2/3 of the excess deaths are in people over the age of 60. If one thinks about it, in our country, about 8% of the population only is over the age of 60. So the mortality rate in people over the age of 60 is probably about 20% greater, 20 times greater than in the age group under 60. Is that an age thing, or is that a comorbidity thing, or is that an association of other things? Is clearly still unknown. The one thing that does point that age in itself might be a factor is the fact that people, as we age, we get greater numbers of the ACE receptor in our nasal and upper airways. And it's the ACE receptor that is the mechanism by which the coronavirus spike protein attaches to our cells and is then eventually incorporated. But again, that's pure speculation, and we don't have any clear evidence that, or a very clear mechanism where age in itself might be a problem. One of the questions that was previously asked is this issue in terms of temperature screening and its value. When we walk into many stores today, we have somebody coming close to us and pointing a thermometer at us and measuring our cutaneous temperature. The experts in the faculty, and particularly in the School of Physiology, tell me that the accuracy of skin temperature measurement in terms of disease detection is particularly poor. They point out to me that the temperature is very dependent on ambient conditions, and I'm sure you've all seen that. On a cold day, your temperature can be low as 32. And we have yet not got into the summer months where I'm sure we'll all be flagged as being at risk and being told to go home. The other issue, which is a bit of an irony, is that the skin temperature goes down just before people become infected, on the basis that the blood vessels in the skin will contract just as one gets ill. And that's obviously well known. There's often a slight drop in temperature, but the cutaneous temperature will go down even more before people develop a pyrexia. There is a question: why is a second wave considered inevitable? Is this based on the experience of the 1918 pandemic? The answer is that it's an observation that has been around in more than just the influenza pandemic in the early part of last century, but also that the behavior of this virus is going to be or the ability to contain the virus is going to be very dependent on the broader population level, immune competence. And that immune competence is still relatively low, and one can use social interventions, but it is something that is going to take a bit of time to develop sufficient immune competence across the whole population. There's a question around what would your response? What would be your response to the perception that clinicians to be produced in 2010 will be as good or not as good as the standard? My understanding is that is twofold in this. The first is that certainly from a knowledge perspective, our students are performing as well as they normally have, and we've been very careful about looking at this over the last few months because we are as concerned as you are. The second area is then, have they had the same amount of clinical experience? And certainly what is being reported to me is that they've been exposed to a similar number of patients. One of the things we did very early on, though, was to try and avoid our students going into the high-risk environments around coronavirus. But recently, that it's become impossible to distinguish our patients to being high risk or low risk, and that there are clearly now need for them to be in that environment as well. But I am told by the clinicians on the ground that their clinical exposure is still quite substantial. There are some areas that will be not as sufficiently trained, but fortunately all of our students will go into some form of internship or community service, and we will be trying to make sure that in those environments they get adequate further training in this whole situation. Question about patient 0 and whether it really was an Italian returnee. It's always very difficult to decide whether a person is patient 0 or whether they were just the first patient who were picked up. So Pat, the first patient who was tested and was found positive in this country was a person who came back from Italy. But certainly, there's now an enormous amount of work being done that is trying to track the progression of this virus through its genes. And it's very likely that that is just what it was, is that this is the first person who had a positive test. And I think we are now getting to see significant evidence that, in fact, the virus might not have arisen out of the Hubei province in China, and that it might have come from elsewhere. And ironically, some of the discussions are showing that it might well have been in the North American environment. But how accurate these things are, and to avoid getting involved in some of the politics and the conspiracies that go around this, I think one needs to always have a very open mind. And I wouldn't be surprised that a lot of disease may well have been around for a few months before that. I mean, certainly the evidence around early detection of the disease in China is already at least 6 weeks ahead of when the first call was put out. But again, we're very, very difficult to decide where we are at the moment. Be keen to continue with a few more questions. It's, however, coming to the end of the hour. Just see if I can find one or two really interesting issues that I haven't picked up here. Here's a question about the feeling of the use of plasma from recovered patients to treat new cases. Certainly well described, and convalescent serum is being used in many other viral environments. So absolutely there, it's an issue in terms of getting enough donors, and certainly only will be used in very sick individuals. And I'm not as yet aware of any large numbers of people who've been treated with convalescent plasma. The question about the calculated excess deaths, taking into account reduced deaths from the trauma-related environment, the excess deaths that are calculated by the MRC separates out deaths reported from unnatural causes and from natural causes. So the excess deaths that we are talking about are excess deaths amongst those with natural causes. The interesting thing is as I'm sure you've seen, that the number of deaths related to trauma has reduced for a period of time, and that really is quite telling. What I find interesting, though, is the speculation and the speculation as to why it is not there. And I certainly am going to be a bit of a skeptic still. There's no doubt that the reduced access to alcohol is something, but I do also think that the reduced access to being transported had a significant component to that. And I do think that a significant number of the or significant proportion of the mortality associated with vehicular transport in this country is related to the fact that we don't observe road rules. I'm going to suggest at this stage, Yumna, that we are at 4 o'clock and that we finish at this time. Sorry, I haven't been able to get to as many of these incredibly interesting questions, amazingly insightful, but really appreciate you all giving me the opportunity to chat to you and hope that it's been helpful. Thank you.
Thank you. Thank you very much, Martin. We covered a lot of ground there. Well done. We left you to your own devices, but you handled it exceptionally well. And, I think it's really important that in times of great crisis and uncertainty, that WITS can reach out to alumni and give you access to scientists and experts that are among the best in their fields in the world. And so we've got a depth of talent at WITS, and so we can look at arranging another session using one or other of the WITS experts to continue this Q&A session. Martin, I'm enormously grateful to you for giving so generously of your time and your expertise. You've given great clarity to a huge number of questions. And I think knowledge brings some comfort and reassurance. And we certainly want WITS to be a lifelong learning experience. So it's been quite interesting for us during lockdown to be able to use webinars to reach out to a global alumni community. And we're reaching far more alumni than we would when we had physical events on campus. So I just wanted to mention that WITS has been on an incredibly positive trajectory. And Martin mentioned the rankings for clinical medicine and public health as well, for that matter, which are ranked in the top 100 in the world. And, we kind of glibly mention it, but if you think about it for a minute, that is an exceptional achievement. It is exceptional for WITS University and for the academics and researchers at WITS. And recently, the academic rankings of world universities ranked WITS as the #1 university in the African continent. So we were heading towards being more open about our centenary. In 2022, we'll be 100 years old. And we're slowly starting to reach out to alumni and conscientize them to the centenary and the beautiful future that is waiting for WITS. So I thank you all very much. In particular, I also want to thank my team, Yumna Patel and Heather Bangwaya. But thank you very much to all alumni out there. Thank you for joining us. Thank you very much for your questions. And I hope to see some of you on campus one of these days. Thank you and goodbye.